Dear Gindrovel, it is okay for you if we record? All right. Could you please share the screen?
Need to start? Okay, sorry. First of all, thank you very much for this invitation. It's a good pleasure for me to be here with you, Ozden, and also with all the people from the Turkey and other invitation. So I have discussion with Ozden before to discuss about the innovative approach in preventive healthcare services, because I want to share with you my experience from Romania, where we have the huge problem, especially with the primary care, where we meet with the some outbreaks in the past, the measles and also the influenza outbreaks, and of course the pandemics of the COVID-19. But unfortunately, these outbreaks of the measles, it is with vaccine preventable disease. So in Romania, the problem was very strong problems, because after the COVID-19 outbreaks, the vaccination coverage decreased very high. In that moment, we have only 78% of the children vaccinated with 3 doses of diphtherotetanic pertussis vaccine, and also with the measles is the same problems. The problem come not only with the decrease of the vaccine coverage, we have the cases. Unfortunately, last year we have 2,000, more than 25,000 cases, from the measles, with 24 deaths, and also the pertussis and the tetanus. That is the vaccine preventable disease illness, and it is very important to reach the high coverage to eliminate and also eradicate this illness. So at the European level, in that moment, we have the strategy who is extend to 2030. And also we have the huge problem in the field, especially in some primary care country where the family physician is the main vaccinator. So the anti-vaccine movement has become very active, especially in social media, or not only after the pandemics. This activity was very strong before the pandemics. Some countries are dealing with vaccine supply problem, but what is important, vaccines are administered in some countries by family doctors, by the pediatrician or nurses. It doesn't matter if the GP is the vaccinator. In all the cases, the GP is involved in vaccine counseling. So in this situation is need to address vaccine misinformation in health workers with the science. It's very important to know the best information to debunking the myth. So we have two tools, very new. The motivational interview (MI) was used in the past in the intervention to change the behavior, especially in obesity or smoking cessation. In that moment, Arnaud Gagnor proposed these tools to be used from the vaccination. Other tools is empathetic reputational interview, who are proposed by the University of Bristol, Professor Lewandowski, in collaboration with University of Erfurt. And in that moment, we have some experience about this. So what is the problem? The problem is the vaccine hesitancy. According with WHO in 2019, the vaccine hesitancy was listed one of the most 10 threat of the international level in public health. So in that moment, we have the people who are accept the vaccination, as you can see, and in the opposite side, it is the refusal. The refusal is very important because there are not very many, there are not a lot of the people who refuse all the vaccine, but it's very, very low. They coming with the information in social media in special and spread, unfortunately, not correctly information. In the middle is something like somebody refused but is unsure. I want to be vaccinated, but I am not sure I will be make this. And accept but unsure, I want to be vaccinated. Please tell me something about some information about this process. So, what are the most effective way to improve the vaccination rate? Gavi, Global Alliance of the Vaccination of Immunization, identify 4 steps to do it. First, remove practical barrier to immunization. That is the duty of the authority. The next 3 items, it is in our obligation. So rethink how we talk about the vaccine. So the counseling the people to accept the vaccination and also the preventive activity is very, very important. It's important to present the vaccination as a social norm. Because in some region, it is a social norm to be unvaccinated. So the situation is exactly opposite. The vaccination is the social norm. And of course, carry out research in different country and context, and that is the duty of the university, in special our colleague who working in the university. So what is the question? What is the best way? Is very important from general practitioner to immediately convince the patient to get vaccinated. Yes, of course, can be do this, but in that moment we have the evidence-based is more important, especially in country where the vaccination is not mandatory, to help the patient to make the best decision to their health. In that situation, the patient make the decision to be vaccinated, and I think is more important from them, especially in preventive activity in the future, because it's important to maintain this behavior. So usually in our practice, we meet with the opposition. The patient don't want to be vaccinated because is perceived as the mandatory vaccination. No. Actually, we must be discussed with the patient, not at linear model. It's very important to use the transaction model, because in our practice, frequently we use the linear model where this model is very effective in crisis situation and emergency encounter time intervention. From the preventive activity, is very important to use the transaction model when we must be persuasive with this patient, especially in prevention when we need to collaboration to change a certain behavior. Effect it is the collaboration between patient and doctor and increased degree of satisfaction with the service provided, and of course is very important to reduce the patient fear and anxiety. So from what we're doing, in 2012, we started the activity of the National Society of Family Medicine of the Immunization Working Group. Immunization Working Group consists in 14 medical trainers in that moment at the national level in Romania, who are a specific aim. Advocacy for vaccination among the general population. We spread the information across the social network. And also, we collaborated with authority in identifying barriers and proposing solutions. And of course, professional support from the vaccinator is very important, this item, because our colleague asked us, what is the best solution? What is the news about this vaccine? I think this vaccine have a huge problem. How can debunking the problems? So we have a lot of the training healthcare workers, GP, nurse in primary care, including community nurse, because they are not in our team. It is paid by the major, by the local community. And there's, of course, other specialists like pediatrician, infection disease, and other specialists. first tools we used in the past was the motivational interview. For example, in 2021, in the November, in COVID-19 vaccination, we going to University of Medicine and Pharmacy in Craiova in the intervention for the automotive platform regarding the problems of the employee. In that moment, in November 2021, we was in the Delta outbreaks, if you remember, Delta wall, and we have a huge refusal of the COVID-19 vaccination. We have a two distinct intervention. One group counseling, group one, consisting 128 people, and other groups who receive the individuals counseling, group two, other 128 people. We provide the intervention GP with physician, occupational physician, trained by University of Medicine and Pharmacy in Craiova and Center for Health Policy and Services in motivational interview. So that is the rule. First of all, we ask open question. We listen the person until the end. We apply verify technique to understand what is happening, and people and the employee must be understand what is our reason. And after that, we check what the person understood for the information presented and how they explain this explanation in their own words. It's very important to reverberate this information. So the results, as you can see, we measure the vaccine hesitancy before and after intervention. That is the results. The score before the intervention was low, and the score increased after the intervention in both group intervention and also individual intervention, and the difference between the score is the same. So as a conclusion, after this intervention, it's very important to apply the motivational interview and other specific technique to increase the willingness to be vaccinated. That is our results. The second intervention was used by empathetic reputational interview, RI, where we try to identify the attitude root, and after that, demonstrating empathy and understand what is the core approach. It is about connecting with people and fostering trust. It's very important to understand what is happening. Halford and also Lewandowski, as I see, I tell you before, from the University of the Bristol and also from the Erfurt University, identify some attitude root. That attitude root is 11 items: conspiracist ideation, distrust, unwarranted belief, worldwide and politics, religion concern, moral concern, fear and phobia, distorted risk perception, perceived self-interest, epistemic relativism, and reactance. Why is important to identify this? Because it's need to adapt our response according with the attitude root to debunking what is the problem. So it is the fourth step from the RI, open question and active listening to identify, is something like intervention motivation interview, but is based to provide immediately the response with the empathy. It's very important, this process. We working with at the university level in Craiova. We have a study consists in 3 types of the intervention. One of the intervention with the general practitioner who are providing the information about the motivational interview. Other 10 general practitioner received the information about the RI, and other 10 was the control group. We have the huge difference. Unfortunately, the data about this study is still under review, and I will coming soon with the article after the publishing in the MPC vaccine. Other intervention in Romania we made through the university. We have our university in the University of Medicine and Pharmacy in Craiova, community programs who are delivered by the students and also with the teachers. So we're going to the school, we're going to the community to provide the information, not only the information regarding the primary prevention, you use the information regarding the secondary prevention from the screening, for example. And one example about this was the intervention about the screening from the colorectal cancer, where we provided our university some information, and not only in the on-site, we're going to the on-site to discuss with the general practitioner and also with the patient directly in the community, but you use the online awareness campaign where we try to send the information to spread to the people who are working in the online platform. So the screening, we use first for the screening the FIT test, fecal immunohistochemic test, and after that we perform the colonoscopy. The results was, as you can see, in the Oltenia region of the Romania. We have the preventive activity consultation from the more than 50,000 people. And we receive from the people on number of the 51,000 more than 51,000 the FIT test. After that, the number of the test positive was 2,825, and only 1,519 people accepted to perform the endoscopy. We have a huge number of the population, 1,312 persons, who are refusing to receive the colonoscopy. That is the huge problem from us, because they don't want to know what is happening with their health. That is the conclusion. In our university, we have the most important communication campaign, especially in the social media, not only the social media, in the TV, and also in the field. So, as the conclusion, it's very important to involve the professional society and university in regain the confidence in prevention. The new counseling technique must be implemented to meet known challenges, and a high professional background must be maintained. Thank you very much, Ozden, for this invitation, and I'm waiting the question if it's...
Thank you very much for sharing your time and also the knowledge that you have gathered. It's evidence-based knowledge. Yesterday we talked about vaccines with also some lawyers. The problem in Turkey is if the patient, for example, for children, the father and mother or the caregiver who is responsible in law is just giving the permission for the vaccines because of some issues, and if there is a problem for, let me say, the father didn't want the vaccine and the children couldn't be vaccinated, the lawyer says that the parents afterwards can say to the family physicians that they didn't enlighten them as appropriate or as good as should be, and blame should put on the family physician. But in here, what is going on in Romania? How can you just overcome this issue, this burden?
It's the same situation in Romania, because the first attitude of the family physician is to put the patient in some difficult situation. If the patient come to me with the refusal, the family physician perceived this refusal as an injury, for example. Why do you accept my hypertension, for example, drugs from the people with the comorbidity, and why don't accept the vaccination? Because you have the same situation not only in the child vaccination, it is the same situation in adult vaccination, where is more huge problem, because in Romania, as you can see in my presentation, we have still 78 counting % of the coverage in vaccination in infants, but in adult population, unfortunately, only 8% received annually influenza vaccination. So it's very, very low level. So from the first time, the family, the GP recite this as the problem. So our intention is to respond at the linear communication. You must be going to be vaccinated without the some explanation. That is the reason why we try to identifying what is the best communication way. So it's very important to be persuasive, to open, ask, to address to the patient with the why do you want to not be vaccinated, to identify after that the possible solution, and of course the attitude route, because we must be aligned with the attitude route with our information. If we put our information against the attitude route, we will lose this fight, because in my opinion, it is one fight, because the coverage of the vaccination is maintaining here at the interference between patient and GP.
Mhm. And for the human papillomavirus vaccination, in Romania, is it covered for government or insurance, or is it free?
In Romania, we have the vaccination from the infant. We have the national schedule of the child, who are paid by the Ministry of Health and achieve the Ministry of Health directly to the pharma. And actually, it is one new mechanism in Romania, starting with 2023 December, when Ministry of Health implemented the compensation vaccination from the adults in special, but not only from the adults. If the child is included in the risk groups, can benefit some vaccination like HPV, for example, and also the pneumococcal vaccination. It's catch-up systems from the people who are not vaccinated, because the pneumococcal vaccination starting in national program of the immunization with 2017 in Romania. And also the vaccination from hepatitis B from some group risk, like the person who received the immunodepressants therapy and another. The transplantation, for example, and they receive the vaccine against MMR, and there's a varicella, the chickenpox, and also the vaccination to recover the schedule from the person with the medullary transplant. So we have the two systems. One, the Ministry of Health paid from the vaccine and distribute free of charge after that to the GP. And the second, we prescribe the receipt, going to the pharmacy, and after that coming us with the vaccine to be administered.
Thank you very much.
Thank you to us then.
And also, we will share with our colleagues. Some of them are on the way to their homes. Is it okay for you?
Yes, of course.
Thank you. Hope to see you later.
Bye-bye.
My best wishes to your family too.
Thank you very much, then. Bye-bye.
Merhabalar, sorun yok umarım. Banu Hocam buyurun. Ee, Hoş geldiniz. As Professor Rosalia has got some health issues, she couldn't just attend. She is in Portuguese now, Portugal now. Thank you very much for help us to change the timeline.
It's okay for me. So I will share my screen right now.
Great.
Okay. So first of all, I would like to thank you for this great invitation and nice talk. I'm sure that we will hear more talks that we will make use of. So within the given time, I will try to talk about the impact of lifestyle choices on the cellular aging process. So my presentation will include a little bit of molecular basics, but this also has an impact on health problems as well. As we are all familiar, aging and health are two intertwined fields since all countries face major challenges to ensure that their health and social systems are ready to make the most of the demographic shift to the aging population. And in 2050, 80% of older people will be living in low and middle income countries, which affects the aging process in total. And the pace of population aging is much faster than in the past. In 2020, the number of people aged 60 years and older basically outnumbered the children younger than 5 years, and this was considered as an alert of the overall worldwide aging population. And between 2015 and 2050, the proportion of the world's population over 60 years is projected to be doubled from 12 to 22%. And this is like a huge increase. Therefore, we have to take some cautions. And at this stage, aging is quite important, the definition of aging. We can define the aging process as a time-related decline in the physiological functions. And at the biological level, this results from the accumulation of both molecular and cellular damage over time, which leads to a gradual decrease in physical and mental capacity of people. We know that there is no typical older person. Some 80 years old have physical and mental capacities similar to many 30 years old, and other people experience like significant decline in capacities at much younger ages. Therefore, there is a great diversity. However, this diversity seen in older age is not random, and large part of it arises from people's physical and social environment. And at this stage comes the definition of the terms biological age and chronological age. We all know that the chronological age is the number of years that we have been alive since birth, while biological age is a measure of how well our body functions based on the age of the cells. Therefore, although chronological age is influenced by only time, biological age is influenced both from genetics, lifestyle, environment, stress, and disease conditions. Therefore, we cannot modify chronological age. However, we can slow down or improve with interventions our biological age. So, scientists that work in the fields ask the question, can there be any hallmarks of biological aging that can guide us in this cellular aging process? And they just thought that the hallmarks should fulfill 3 criteria to be a hallmark for biological aging. The first one is that it should manifest during normal chronological aging process. The second is that its experimental aggravation should accelerate the aging process. And as a third, its experimental amelioration should retard the normal aging process. And considering those 3 criteria, they have proposed 9 hallmarks in 2013, tentative hallmarks of the aging. And within the last decade, as the research continued, they have added 3 more tentative hallmarks of biological aging in 2023. And among those 12 hallmarks of aging, epigenetic alterations came into took quite a lot of attention because recently a new theory of aging has been proposed. We know that with our lifestyle or with our daily lives, we both face with exogenous and endogenous DNA damage, and our DNA repair pathways are of quite importance because if they are not enough, then this leads to a genomic instability, which leads the formation of all the hallmarks of the biological aging. However, only getting a DNA damage is not enough. We know that the epigenetic changes influence gene expression quite a lot. And these increase addition of methyl groups on DNA or addition of different chemicals on histone proteins that can basically remodel the chromatin from euchromatic to heterochromatic or vice versa. And we also know that there are non-coding RNAs that can regulate the gene expression. And all these are considered as epigenetic changes, which are changes in gene expression that does not arise from DNA sequence changes, but basically arise from above the genome regulations. In 2023, scientists just proposed a new theory of aging, which is the information theory of aging. Basically, this theory states that aging results from loss of information. If you consider your genome as a computer and your epigenome as a software, basically after a time, the software is not enough to show the real power of your computer. Or when you consider your genome as a CD that plays the well music, upon time, when scratches occur on those CD, basically the system cannot read the information there, and basically the music stops and restarts again, and it does not play a good sound at this stage. So basically, age cells resembles those too. They say that we age because our cells forget the original intentionality that is encoded in the epigenome. This makes sense because we have our DNA. However, with the lifestyle, with the toxins that we face every day, with our eating and drinking habits and our daily habits, new chemicals can be added on DNA molecules. So DNA methylation-based epigenetic regulation can take place. Above that, histone proteins, where our DNA wraps around, can be modified, which leads to gene expression changes. And above that histone modification, there's a superficial level that are related with transcription factors that again affects the gene expression. So we have a path that is clear. However, we also have some chemical tags both on DNA and proteins that basically opens up or closes up genes, and it basically is a dynamic stage and is reversible. So what they have shown in their study, the group that proposed this information theory of aging, is that when mice ages, the epigenetic entropy increases, the functional tissue decreases, and the dysfunctional tissue increases. And by just reprogramming the differentiation state of the cells, they have shown that they reverse the epigenetic clock of the old mice to a young mice. So they showed that by manipulating the epigenome, aging can be driven forward or backward. And additional studies supported this. Another study showed that the mitotic hypomethylation clock just restrains the aging cells. They showed that upon cellular division, upon aging process, the methylation, the global DNA methylation decreases, which results in an aging cell phenotype, and therapies that modulate this methylation loss and that eliminate hypomethylated cells could alleviate the aging association diseases, including cancer. So cellular aging, we know, is linked and influenced by many factors, and lifestyle parameters is among those factors. So diet, physical activity, sleep, stress, and substance use basically affects our epigenome in a close way. So by modulating those lifestyles, we can basically keep our biological age at the epigenome level much more younger. If we quickly look at them one by one, caloric restriction is the firstly tried change in diet. We know that it has an impact on several genes and signaling pathways that plays role in aging process, and it is a conserved mechanism. So caloric restriction leads to lifespan extension in all organisms, so it is evolutionary conserved. We know that antioxidants, polyphenols are related with the telomere length, or different types of diet affect the lifespan as well. Another study, it's also a recent study, have shown that by applying caloric restriction, we can extend our lifespan 10% if we just apply it throughout 24 hours. However, if we apply caloric restriction in the daytime while we're active and do not eat anything when we are inactive, basically we can just extend it more than 30%. So even a 12-hour fasting during the rest phase is sufficient for maximum age lengthening with caloric restriction. Also, the nutritional status is quite important, and it starts from maternal nutritional status. A study have shown that the pre-pregnancy body mass index and weight and body fat percentage is negatively correlated with the telomere length. So the more the body mass index, or the more weight we have, or the more body fat percentage we have, the less telomere length we see in placental and cord blood telomeres. Also, we know that lifestyle can mediate the nutrient sensing pathway. So genes that play a role in nutrient sensing pathways are affected from the aging process. They are deregulated, and this is also when you look at these genes, an epidemiological study has shown that basically these genes are also related with the cognitive aging, which basically leads to some age-related diseases, including Alzheimer's or Parkinson's. We know that our diet is quite important. There are some healthy diets, and there are some diets that proposes some risk for the age-related diseases. We know that Mediterranean diets, including that are rich in vitamins or long-chain omega-3 acids, are healthy diets in means of dementia, so they prevent or postpone the symptoms of dementia, while Western diet that are rich in fructose, sugars, or processed foods just constitutes a dementia risk. A study called Calorie that was performed in 3 different clinical centers in USA was a phase 2 multi-center study with a randomized control trial in young and middle-aged people that are healthy, non-obese, but have a slight more body mass index that changes between 22 and 27.9. And 2 years of moderate caloric restriction on these people have shown a significant reduced multiple cardiometabolic risk factors in young non-obese adults, which suggests the potential for a substantial advantage. And in 2024, recently, the genomic data resource of this program also has been released. Apart from diet, physical activity known to affect the cellular processes in close, including the influence on mitochondrial biogenesis or telomerase activity or inflammatory markers or epigenetic modifications. We know that physical activity and exercise has been shown to affect epigenome and systemic metabolism, including glucose metabolism, lipid metabolism, or adipose metabolism, as well as gene expression. And beneficial effects of exercise has been shown in both mitochondrial health and cardiovascular health due to those different pathways, including regulation of inflammation and metabolic state and epigenetic. We know that a healthy diet and physical activity is quite important, but sleep is also quite important because there is a circadian regulation within our body. A circadian clock is an innate timekeeping molecular mechanism that basically maintains the rhythmicity of the biochemical, physiological, and behavioral function that are independent of external input. And in 2050, 3 scientists, including Aziz Sancar, also took a Nobel Prize at the molecular level for showing how cells repair damaged DNA and safeguard the genetic information. In their study, they have shown that the core circadian clock basically controls the rhythmic expression of a DNA repair genes, and the entire excision repair system exhibits the same type of daily periodicity. And some at 5 a.m. The DNA repair genes are at their minimum, while at 5 p.m. they are at their maximum. This is quite important because DNA repair mechanism is required to remove the DNA damage in order to prevent the genomic instability, which is one of the hallmarks of cancer. Therefore, this rhythmicity is quite important. They also have shown rhythmic changes in chromatin states that are altered in circadian manner. Also, a common mechanism relying in cyclical change of various memory-related processes has been shown. Sleep disturbances has been shown to increase the hallmarks of aging, but supported by several studies, which shows that basically keeping that sleep cycle is quite important. A recent study that was published in Scientific Reports was shown that we have a best sleep time period for our phenotypic age, which is around like 7 hours for humans, and sleeping less or more leads to an increase in our phenotypic age. So not only sleeping less, but sleeping more also affects our phenotypic age. And they have shown that basically the long sleep duration can benefit from regular exercise activity. So we can just reduce that phenotypic age by adding exercise, which shows that basically the cellular aging process is affected from sleep and exercise quite a lot. Also, psychological stress can affect the cellular aging process through telomere shortening. Several studies have shown that higher levels of maternal stress are associated with shorter cord blood telomere length. And there are like several studies that shows the adversity in childhood have an impact on telomere length. So basically exposed individuals show signs of accelerated erosion in their telomeric ends from early age from studies that were performed on different ethnicities. Also, another study have shown that greater count of chronic difficulties, particularly during childhood over time, predicted a greater telomere length loss, which also shows that chronic stress has an impact on telomere length, which affects the aging process. Our lifestyles, including our exposure to toxins or smoking or alcohol, is also highly regulated with the cellular aging. We know that smoking affects our epigenome, makes some DNA methylation events or histone modifications. Therefore, smoking affects our epigenome quite a lot, and studies have shown that if we are exposing uterus smoke, then our telomere length basically decreases more compared to a person who has no in-uterus smoke exposure. Alcohol exposure, although giving direct damage to molecules, it also affects epigenome quite a lot, which can lead to a disrupt the epigenome regulation of gene expression. Or the chemical agents, including the air pollution, shows some premature biological aging and increased risk of age-related diseases. A study that was performed in Iran just showed that higher exposure to air pollution and traffic at kindergartens and residential home were associated with shorter relative leukocyte telomere length in preschool children. Also, our working environments are quite important. Exposure to toxins, including like chromium, cadmium, or lead, has been shown to increase the oxidative stress and shorten telomere lengths. Or the pesticides on the foods that we are in interact with has been shown to be related with increased inflammation and oxidative stress and altered methylation-related patterns, which basically shows that they also affect the hallmarks of aging. Or radiation is known to generate reactive oxygen species, which causes like biological molecule oxidation. And they also have shown that UVA radiation induced direct DNA oxidations or telomere erosion, which is also related with the aging process. So those examples shows us that there is a crosstalk between an unhealthy lifestyle and aging. So a sedentary behavior or high-fat diet or sleep disturbance or psychosocial stress can all affect the nutrient sensing networks, which leads to deregulated nutrient sensing, which is a basic hallmark of aging. And it can also accelerate the development of aging and cardiovascular diseases through different mechanisms. A study that was performed in Finland in more than 1,000 participants between the age 60 and 77 has shown that basically an intervention group that changed their lifestyle in the areas of diet, physical activity, cognitive training, social activity, and monitoring cardiovascular risk factors just showed a greater improvement in their processing speed, in their overall cognition, and in their executive function and complex memory tasks compared to control group who received regular health advice. So that shows that basically healthy lifestyle or changing our lifestyle can lead to an improved biological age and biological age-related diseases. We said that epigenome is quite important, and it's now the most recent theory of aging. How do we measure those? Apart from telomere length, we can use epigenetic clocks where we just look different methylation areas and there are several different epigenetic clocks where Horvath's is the mostly used one. The tissue samples, which clock to use depends on what kind of tissue sample we are using or what kind of biological sample. Some of them can be performed only on blood, some of them can be performed on tissue samples, and they use different regression models that just calculate approximate epigenetic clock and their correlation with the chronological age is being performed. Those clocks shows that with the physical activity and healthy diet, we can decelerate the aging process, while with low socioeconomic status, low education level, or smoking or alcohol use or several infection, we can basically accelerate the aging process. And those epigenetic measures highly correlate or associate with the incidence of the common disease states, including the age-related diseases. So what is there? What this research basically adds up to clinical and public health? First of all, those research just helps us to prevent the age-related diseases, because if we understand the molecular mechanisms, we can somehow try to prevent them. They are important for the personalized lifestyle interventions, and basically after a while, those aging biomarkers can also be integrated in practice in the future. But of course, at this time, we have some challenges and research gaps. The first one is the causality versus correlation in lifestyle studies. We see several correlations, however, the causality is limited. Causality studies are limited, and there are several inter-individual variability in these studies. Therefore, we need more longitudinal multi-omic studies. So as final slides, I want to concentrate on the demographic changes both worldwide and in Turkey. In Turkey, we see that the population growth rate is decreasing and is going to decrease. And in 2050, the World Health Organization projection shows that we will have more aged population compared today. And the life expectancies, although above the world average, we see a general decline in the life expectancy at birth overall, but the most importantly is the healthy life expectancy. Although we are again above the world average, there is a decline in recent years. And also the Hugh Triple Billion target projections show that we are somewhere in the middle of the for the healthier population and universal health coverage, but there is more that we can do and improve ourselves. What the world does is that United Nations just proposed this decade as a decade of healthy aging, and together with World Health Organization, they work on 4 different fields, including age-friendly environments, integrated model care, long-term care, and combating ageism. And basically, this aging research adds up to combating ageism and integrated model care parts. So as a conclusion, lifestyle has a measurable and modifiable impact on biological aging, and basically multi-domain approaches offer synergistic benefits. And translational research and policy integration is quite important, because we have our way. However, it depends on us if we will make a smooth way or a crowded way in order to see our way. So I would like to thank you, and if you have any questions, I can take. Thank you.
Dear Professor Banu, Demir, thank you very much. It was, you just make us see your diligent work here, because you're working in basic science. And now Snežana Knežević is with us, and she is a clinician, and she is also working about lifestyle medicine. But while you two come together, you just make us understand that we are just saying about lifestyle medicine and talking about this, but it is also affecting also our DNA, also our telomeres, and the things that happening to us is also seeing how the life is going on. Thank you very much.
Thank you.
Snežana, would you like to say something, our professor, or?
Hello, everybody. I'm pleased to join this congress, and happy to continue after Professor Demir, as we are speaking about lifestyle and lifestyle medicine and all opportunities that I think we didn't manage enough in our daily practice. Can I share my presentation?
Yes, of course.
Thanks. So I am, as you already introduced me, thank you, Snežana Knežević, a general practitioner from Serbia. Can you see presentation? Did you share a presentation? Is that everything fine?
I muted myself. If we could make the slideshow, we can see full screen for the presentation.
Okay, thanks.
Great.
So I would like today to speak about implementation and possibilities of lifestyle medicine in menopause women. We already heard from Professor what is lifestyle medicine, but I would like to just in short again make a definition of lifestyle medicine and what everything can be useful in managing chronic problems and modern lifestyle and about all on the woman's health. So evidence-based clinical care that supports behavior changes through person-centered techniques to improve well-being and social connections, healthy eating, physical activity, sleep, and minimization of harmful substances is only one of definition of lifestyle medicine. It is supposed to be effective antidote to the chronic disease problems, and of course requires education for all clinicians and public health professionals, researchers, scientists from multiple areas, and educators working together to affect changes in lifestyle in modern society. Of course, evidence-based science with a lot of documented clinical outcomes in globally supporting unhealthy lifestyle changes. And of course, my particular interest was can lifestyle medicine be effective in menopausal symptoms management, and in the rest of my presentation, I will focus on that period of a woman's life. Already mentioned, but I would like just for short to remind what are 6 pillars of lifestyle medicine. It's nutrition, physical activity, restorative sleep, stress management, substance avoidance, and healthy social connections. What include, according to lifestyle medicine, 6 pillars: nutrition, predominantly whole food consumptions, plant predominant food, and according to women's health in menopause and management of symptoms, it is well documented that healthy nutrition can optimize the hormonal functions. When we speak about physical activity, it is well known that improves metabolic health, bone density, and improves mental health and mood under mental health issues. Restorative sleep is, of course, very important. as supports cognitive functions and emotional resilience. In modern society, speaking about stress management is, I think, particularly important. And under 6 pillars in lifestyle medicine, it is a lot of investigations on mind-body techniques, and it is proven that they improve autonomic functions. Among substance avoidance, it's tobacco, alcohol, also illegal drugs consumption, and avoidance of those substances can reduce a lot of risk factors, among them cancer or cardiovascular risk. The last pillar of lifestyle medicine are social connections, and they can change immune function and psychological well-being. Just a little about menopause. That is known as a natural biological process marking the age of reproductive years. Clinically defined as 12 consecutive months without menstruation. Among most of women, it occurs in a period of 45 to 55 years of life. Why is happening? Because of declining ovarian function and hormonal production, estrogen, progesterone, etc. Menopause has 3 phases: perimenopause, menopause, and postmenopause. Perimenopause as a transitional period include hormonal fluctuations and marked symptoms in that period of menopause. The same menopause is point marking 12 months without menstruation, and the postmenopause period following all confirmed menopause period. The most frequent symptoms in menopause are divided in several groups. First of all are vasomotor symptoms with hot flashes, night sweats. The other group of symptoms are genitourinary with vaginal dryness, lot of urinary issues, etc. And symptoms in psychological area are I think predominant with mood changes and sleep disturbances. And because of decreased hormonal function from ovaria among women in menopause are increased long-term risks of different diseases such as osteoporosis, metabolic disease, cardiovascular disease, and problems in mental health issues like cognitive functions. What are management approaches in menopause? On the first place, we can mention different medical interventions, including hormonal and non-hormonal medications. Psychological support, like counseling or education to manage symptoms and improve overall health. And on the third place, especially interesting for us today, are lifestyle modification, such as exercise, nutrition, or sleep management. Conventionally, symptoms focused approach with pharmacological interventions we can meet frequently. Hormone replacement therapy as a primary solution is known that can have a limitation and a risk of diverse effects. Reactive strategies addressing these problems after emergence can be problematic. What about lifestyle medicine, paradigm shift, and published papers about lifestyle management approach to address symptoms predominant in menopause women. What is the good aspect of lifestyle medicine approach on prevention-oriented strategies? Because this approach can reduce symptoms before onset. On the second place, we can mention root cause focuses in hormonal balance and metabolic health. And not less important, we should mention that all complementary roles change effectiveness of medical interventions. What is known about lifestyle approaches managing menopause symptoms? Important area because 75% of women experience menopause symptoms. Among them, 25 report moderate to severe impacts. But among all menopausal women, only 25 seek for treatment and visit a doctor because of those symptoms. So a lot of a percentage of women that do not seek for treatment can be opportunity for every lifestyle-based solutions. Healthy lifestyle approach reduce long-term health risk like cardiovascular, metabolic, or bone health risk. Non-pharmacological lifestyle modifications can act simultaneously to improve symptoms. And because of adverse effects on hormonal treatment, lifestyle approaches can be useful or alternative for women who cannot use hormone replacement therapy. In lifestyle approaches, it is important to have collaborate approach between different specialists, and it is area where we can empower our patients on their active participation in managing menopausal symptoms. What is known about lifestyle medicine interventions that can improve menopause symptoms? They bring greater protective effect. They are bringing synergistic benefits when combined with hormone therapy. They can be useful in resource-limited settings, and about type of lifestyle medicine intervention that are the most useful. We should manage that structured programs bring a better adherence than only recommendation in menopause women visits to our office in consultations. Progressive behavioral goal settings are more effective than only information given in our clinics, and about motivation of managing symptoms in menopause women with lifestyle medicine interventions. Educational focus should be on long-term health benefits, and that is the way to exchange motivation in this group of patients. When we talk about prescribing and counseling physical activity among one of the pillars of lifestyle medicine interventions, published research showed that physical activity significantly improves menopausal quality of life. Physical activity in areas of AIDS weight management is also useful. Physical activity exchanges psychological well-being and reduces depressive symptoms. Menopause woman who is physically active has fewer urogenital symptoms, and that is enough scientific evidence that we should counsel menopausal woman on physical activity. What type of physical activity? It is well known about guideline that 150 minutes per week of physical activity of moderate or intensity activity is recommended. What about menopause symptoms? It is known that moderate physical activity intensity is more effective than low or high intensity. Strength training is more effective to bone density and metabolic health. And there are scientific works that prove that yoga with combined movements, breathing and mindfulness reduce menopause symptoms. Of course, according to other comorbidities, individualized program should be revised. What about nutrition? Mediterranean diet is proven to be beneficial for joint discomfort. High legume intake reduces symptoms of menopause severity, improves psychological health. Lower red meat consumptions brings better general health outcomes. There are research that soy isoflavonoids significantly reduce vasomotor symptoms. Plant predominant diet with soy, according to research, almost 19% reduce hot flashes and 50% of symptoms are eliminated within 12 weeks. Essential nutrients are in the whole population, of course, beneficial and among menopausal women. The other dietary approach to stop hypertension as reduce inflammatory markers is also beneficial for a menopausal woman. But despite the strong evidence-based research, it is also known that most women show only moderate dietary adherence in this period of life. What about substances avoidance? Evidence-based said that about smoking, there is dose-dependent relationship with menopause symptoms severity. A woman with 20 to 30 years of smoking history has worse symptoms in menopause. Early cessation before 40 years of life reduce risk of near never smoking levels. Particularly high risk we have in combined smoking and obesity. About alcohol, 30% of women increase consumption during menopause. 70% due to psychological distress and 30% to manage their menopause symptoms. Moderate consumption of alcohol is associated with a later menopause onset. It's interesting finding, but there is no protective effect of alcohol. Restorative sleep is important pillar of lifestyle medicine because the most sleep problems are the most common and debilitating menopausal symptoms. The most women have a frequent awakening and increased awake time. In this area of life, obesity getting worse, all those symptoms, and unhealthy sleeping negatively impacts on overall health and relationships and work performance. Research showed that there are some effective behavioral interventions like cognitive behavioral therapy, which significantly improves sleep quality. Physical activity, previously mentioned, also benefits to sleep quality and different mindfulness and relaxation techniques can be a safe alternative to medication. What about stress management as a fifth pillar of lifestyle medicine? Critical for overall quality of life And in menopause woman, it is shown that yoga with not less than 20 weeks intervention can manage and reduce menopause symptoms. Different mindfulness intervention can decrease stress also, and sustained benefits are shown in 3 months follow-up. What are the other options to manage stress in menopause women? Cognitive behavioral therapy, hormone therapy, but non-pharmacological options has a minimal side effect. Social connections also important. Participation in different social group is shown in menopause women that increase physical activity levels and reduce climacteric symptoms. Networks foster positive attitudes toward this period of women's life. Benefits primary in mental health, and social connections cannot directly reduce vasomotor symptoms, but can help in managing chronic conditions are increased in menopause risk. How to educate our menopause women to implement lifestyle medicine interventions in their daily life. Different not less than 8 weeks program improve knowledge, quality of life, and self-management. We should focus on health literacy among our women, recognize the abnormal symptoms, and of course to send women to specialists if they require medical attention. How to implement lifestyle medicine interventions in daily life with patient-centered approach, integrate whole 6 lifestyle medicine pillars, and support both symptoms management and long-term health effect with our women. What about role of family general physicians? They have strategic position for most menopause women, and they have unique opportunity for early intervention and prevention, and opportunity to deliver continuity of care. Surveys show that there is a strong connection between nutrition and physical activity guidelines in reducing menopause symptoms. That there are limited integration of sleep and stress management in family physician general practitioner daily practice, and as key barriers there are barriers in behavioral changes, and of course time limitation in daily work of family physician. How can we optimize the care by interdisciplinary collaboration and evidence-based approach as a first-line approach in daily practice. What we can conclusion about this short presentation. That there are a lot of benefits of implementing lifestyle medicine in menopause symptoms management. Why? Because lifestyle medicine approach is a comprehensive approach to address multiple symptoms, reduce symptom severity, improve quality of life in menopause women, and exchange health literacy and self-management. What should be future directions in this approach? To integrate lifestyle medicine in standard care protocol, to focus on causal rather than symptoms management, and to improve in primary health care patient shelter collaboration model for comprehensive care. Thank you for your attention.
Dear Suzanne, thank you very much. And just finishing with William Osler was very interesting when who to treat and what is the root reason. And there's a question. Dear Ece Yokuş says that thank you for the comprehensive speech. Do you suggest calcium intake with diet or additional supplement?
Of course.
Which one?
Of course, Mediterranean diet is shown as one that can be in the primary healthcare office prescribing to our menopause women, and the way to improve adherence of menopause women to Mediterranean diet is the best option to reduce.
Should they get additional supplement?
Sorry?
For calcium, should the patient get additional supplement?
No, I didn't find in actual literature that parts of recommendations.
Thank you very much.
Thank you.
Thank you for sharing your time with us. I hope to see you again.
Thank you for invitation.
And now we will have Paolo, but Paolo will connect half an hour later. So there's no problem with the panel desk if you'd like to be here. Thank you, Suzanne.
I'll start then. Hi, everyone. I'm Melis Kartal Yandım from İzmir University of Economics, Faculty of Medicine, Department of Medical Biology. I've been doing research on cancer molecular biology for approximately 17 years. And today I'll talk about the lifestyle and cancer development interaction. Cancer is a group of diseases characterized by the uncontrolled proliferation of cells, and multiple breakdowns may cause this cancer. And some authorities define cancer as a chronic metabolic disease. In normal conditions, sorry, I'll show the laser. Yeah, in normal conditions, in normal cell division, the cell divides into two identical cells, and this division goes on. However, mutation may arise in DNA, and this DNA damage can be repaired in healthy cells. Or if the damage is too excessive to be repaired, then this cell is removed from the body by cell death mechanisms. However, in cancer cells, these damaged cells cannot be removed from the body, or the damage in DNA cannot be repaired, and these mutated cells continuously proliferate. And during these divisions, the additional mutations may occur, and by the accumulation of these mutations, uncontrolled growth occur. Statistically, according to the report of International Agency for Research on Cancer in 2022, number of new cases of cancer is approximately 20 million, and number of deaths is approximately 10 million. And about 1 in 5 people develop cancer in their lifetime, and approximately 1 in 9 men and 1 in 12 women die from the disease. And by the 2040, it's estimated that approximately 28 million new cases of cancer, there will be 28 million new cases. And when we look at the top 5 cancers in males, we see lung, prostate, colorectal, stomach, and liver cancer. And in females, we see breast, lung, colorectal, cervix, and thyroid cancers. And overall, in both sexes, we see lung, breast, colorectal, prostate, and stomach cancer. And carcinogenesis is the development of cancer by transforming healthy cells into cancer cells. As mentioned before, damages in DNA in normal cells can be repaired in healthy cells. However, if there is a DNA damage and if a failure occurs in DNA repair, then these mutations can activate growth-promoting oncogenes, and these activation leads to unregulated cell proliferation, which finally leads to malignant neoplasm phenotype. And there are approximately 10 hallmarks of cancer cells, and of course, by some studies, these hallmarks are growing day by day. But we can say cancer cells can evade from growth suppressors, and they can escape immune destruction. They can escape from apoptotic signals. They can resist cell death. They can promote inflammation, and also their metabolism is altered. And we can classify the causes of cancer like endogenous factors such as genetic mutations, hormonal and metabolic factors, environmental factors such as radiation, environmental carcinogens, viruses, and also exogenous factors like lifestyle factors, including diet, physical activity, tobacco, and alcohol. And by the time these factors cause some alterations in cellular events, and these cells proliferate in an uncontrolled manner, and they cause invasive cancer. Hereafter, I'll focus on lifestyle and cancer, and I'll start with their actually combined effect on cells. We know there's an interconnection between diet, physical activity, obesity, and the other lifestyle factors and cancer. They can affect DNA repair, they can affect insulin resistance, they can affect cell cycle, proliferation, cell differentiation, and also they can affect carcinogen clearance. Now we know vast majority of cancers are caused by lifestyle, not bad luck. And lifestyle changes could prevent more than 40% of malignancies, which is very high. And we can prevent cancer cases by lifestyle interventions. We'll see how. Obesity is characterized as a chronic inflammatory state, and it can induce pro-inflammatory cytokines, cytokine production, and we know obesity is closely related with the other factors like diet and physical activity. It has significant impacts on cancer development. We know obese patients, in obese patients, inflammation is triggered, inflammatory pathways, and this inflammatory pathways causes the pancreas to produce more insulin. And this high insulin and high insulin-like growth factor 1 can suppress apoptosis, which is very important cell death mechanism. Programmed cell death mechanism, and it suppresses apoptosis. However, it triggers cell proliferation, lymphoangiogenesis, and also angiogenesis. And in addition to this insulin, we know extra fat cells also make estrogen. And in combination with estrogen and insulin can trigger the cell survival and cell proliferation pathways. So this can cause cancer. And we know the people with high BMI, like 25 BMI of 25, can influence cancer growth by providing a constant supply of glucose for aerobic metabolism. Mechanistically, as mentioned, in obese patients, inflammatory signals are overexpressed. So these inflammatory signals are related to the cell signaling pathways related to cell proliferation and cell survival, like PI3, AKT pathway, JAK-STAT pathway, or NF-kappa B pathway. And metabolism is altered in these patients. And cancer cell proliferation increases in response to these events. Additionally, tumor microenvironment is affected by these inflammatory signals as well. We'll see. For instance, in breast cancer patients, obese breast cancer patients, tumor hyperinsulinemia activates the pro-inflammatory cytokines, and by these cytokines, the cells in tumor microenvironment are triggered to proliferate. And also, the other pro-inflammatory cytokines are found higher in obese breast cancer patients, and combinationally they cause cell proliferation, angiogenesis, and cell survival. In addition to breast cancer, there are several cancer types related with obesity, like thyroid cancer, breast cancer, pancreas cancer, colon cancer, kidney cancer, or multiple myeloma. And they cause really important factors. Yes, the other factor is physical activity. We know inactive individuals are more prone to hypertension, suppressed immune response, abnormal cholesterol, increased cancer risk, and obesity as well. And we know physical activity is very important for immune modulation. Active lifestyle increases the levels of cells, levels of phagocytic cells, we can say. So phagocytic cells like natural killer cells, macrophages, or dendritic cells. And these cells can immediately detect cancer cells, and they can lyse cancer cells by phagocytosis. However, in sedentary lifestyle, the level of Tregs or Th2 cells are very high. So these cells can secrete pro-inflammatory cytokines like IL-10 and IL-6. And in these individuals, the levels of the other phagocytic cells are low, and these Tregs and Th2 cells induce pro-inflammation and inflammatory signals. However, we know physical activity is very important for immune modulation, and by increasing physical exercise, we can increase the phagocytic cell levels in individuals, and then we can decrease tumor volume in these individuals. Yeah, here is the example for it. In lung cancer patients, by physical exercise, physical activities, the levels of myokines are increased. So myokines are released from the contracted muscle cells, and then these myokines enter the vascular circulation, and they can affect tumor microenvironments. They can induce apoptotic signals, and they can inhibit proliferation in lung cancer. Yes, diet is the other important factor for cancer. Nutrition quality and quantity may have important effects on cancer generation. We know these nutrients can affect inflammatory signals and immunity, and by the effects of aging as well, it can cause cancer. And we know by modulating this diet, actually chemotherapy resistance may arise in depending on the nutrition quality and quantity. There are multiple axes of diet and cancer interactions. So dietary intake can affect nutrient metabolism, lipid metabolism, carbohydrate metabolism, and also it can affect nutrient-sensitive signaling pathways like autophagy, like insulin signaling, and also it affects gut microbiome. And overall, they can induce tumor growth and progression. In this regard, I'd like to touch on ketogenic diet. It's a little, we can say it's a double-edged sword. Ketogenic diet is characterized by low carbohydrate, high fat, and adequate protein intake. The effect on cancer cells is a little bit controversial because we know, okay, we limit the glucose uptake, carbohydrate uptake, intake. So by limiting this intake, we can decrease tumor volume in cancer patients because they'll starve for glucose, and then the cell death mechanisms like autophagy will be triggered. However, ketogenic diet may have some side effects in individuals like cachexia, and this may be lethal in some cases. So there are some studies to inhibit, to suppress the effects of cachexia, for instance, dexamethasone can suppress cachexia, and by combining ketogenic diet with dexamethasone can affect on tumor size. In addition, there is an unexpected role for ketogenic diet. It triggers metastasis in some cases. So there's a study with the mice with breast cancer. So the authors compared the control group and the mice with ketogenic diet. Okay, it decreased tumor volume. Ketogenic diet decreased tumor volume in mice. However, they saw that this ketogenic diet increases metastatic pathways. So number of metastases increased as compared to control group. So they reported that lung metastases occurred in response to ketogenic diet. So the tumor volume in breast decreased. However, metastasis in lung occurred in response to ketogenic diet. In dietary factors, I'd like to touch on dietary polyphenols as well. We know there are several polyphenols that may have important effects on cancer development. Resveratrol, curcumin, apigenin, and also quercetin are very important examples for these polyphenols. So they can affect autophagy, angiogenesis, apoptosis, and also the other signaling pathways, and they can induce cell cycle arrest in cancer cells. Additionally, these polyphenols can also affect microbiota as well, and they can decrease tumor volume in cancer patients. I'd like to give some examples from our studies. So we have some studies related to these polyphenols on leukemia cells. When we treated imatinib-sensitive and imatinib-resistant chronic myeloid leukemia cells with resveratrol, our results show that resveratrol decreases cell proliferation in a dose-dependent manner in both imatinib-sensitive and imatinib-resistant cell lines, and also it increases apoptotic effects in these cells. And in case of quercetin, we use T-cell acute lymphocytic leukemia cell lines, acute myeloid leukemia cell lines, and also chronic myeloid leukemia cell lines. And our studies show that in each cell line, quercetin decreased cell proliferation in a dose-dependent manner, and also it increased apoptosis as well. And in case of apigenin, again, we treated imatinib-sensitive and imatinib-resistant chronic myeloid leukemia cell lines, and our studies showed decreases in cell proliferation again in both cells, in imatinib-sensitive and imatinib-resistant cell lines, and it increased apoptosis in response to treatment with apigenin. So overall, it's recommended that 2 serves of fruit and 5 serves of vegetables every day is very healthy for cancer prevention. And we need to try eating as much as fresh products as we can to be healthy and to prevent ourselves from cancer. So in summary, there's an interconnection between diet and physical activity, and both of them can generate a healthy and non-obese state by promoting immune response, by decreasing inflammation, and also optimizing DNA repair and stability. Yes, the other factor is tobacco use. We know there are more than 7,000 chemicals in cigarette smoke, and also there are more than 70 different carcinogens in cigarette smoke. And these carcinogens can cause mutations in DNA, how they can cause G to 2 transversions in cancer cells, and they can cause cancer generation. Tobacco use is related to several types of cancers in esophagus, lung, bronchus, liver, stomach, pancreas, colon, or uterine cancers. And we know it causes epigenetic alterations, and also it causes some mutations in cells, G to 2 transversions, and it causes cancer in patients. Alcohol is the other factor that may have important effects on cancer development. We know alcohol Actually, alcohol dehydrogenase is important for the conversion of ethanol to acetaldehyde. And this acetaldehyde is converted into acetate by the activity of aldehyde dehydrogenase. In healthy individuals, it's okay. The alcohol is converted into acetate and it's used as an energy source. However, if there's a mutation in this aldehyde dehydrogenase, or if there is a high intake of alcohol, so the enzyme cannot be enough to convert acetaldehyde to acetate, or if there's a mutation as well, as mentioned before, then there may be some damages in DNA, there may be some chromosome rearrangements, and this may cause cancer. Here you can see an example from the esophageal cancer. Again, acetaldehyde can accumulate in cells, and this acetaldehyde can cause DNA damages, and it can cause uncontrolled proliferation of cells. Yes, it's associated with several types of diseases, several types of cancers in voice box, in breast, in colon and rectum, in mouth, throat, and esophagus. And we know approximately 500 deaths each day from excessive alcohol use, and that means about 200 people every hour. It's too high, and we know there's no safe level of alcohol consumption, so we need to decrease alcohol intake to prevent ourselves from cancer. UV radiation is the other important factor for cancer development. We know, depending on the length of the wavelength, we can classify these UV, UVC, B, and A. And this UV light can cause DNA damages in cells, and these damaged cells can proliferate in an uncontrolled manner again, and it can cause skin cancer. And this skin cancer can be classified as squamous cell carcinoma, basal cell carcinoma, and melanoma. And they may be lethal for the patients. So in order to prevent ourselves from skin cancer, we need to use broad spectrum sunscreen, and also we need to protect ourselves from direct UV light, direct sunlight, by using hats and sunglasses. And we need to prevent ourselves from using sunbaths, solarium baths. Actually, they can cause cancer, melanoma, and also lung cancer in patients. So it's important. So in summary, we can say these all lifestyle factors may have important effects on several factors, several cellular events. They are very important for immune modulation, and they can induce epigenetic alterations as well. And by these immune modulation and epigenetic alterations, they can cause cancer development. And in 2018, American Institute for Cancer Research reported some cancer prevention recommendations regarding these lifestyle factors. And also, finally, we can say we can reduce cancer risk with healthy lifestyle, like moving our body, eating well, maintaining our healthy weight, and quitting smoking or don't smoke, and practice sun safety, and don't drink. These are important interventions for lifestyle to prevent cancer. And we know the cancer miracle isn't a cure. Its prevention is important, and the effect of lifestyle factors is very important on cancer cells, very high. It's 40%, and we can prevent cancer by these lifestyle interventions. Yes, I'd like to thank you for listening, and I'd like to thank the organization committee for their invitation. If you have any questions, I can take them.
Thank you very much, dear Paolo, Lauriola, and also dear Prof. Snežana, Knežević are with us now. I can see them. And thank you very much for just coming here and listening to us. Lifestyle intervention is very important, and you just give the information, evidence-based information about how the individuals can affect it. And maybe, dear Paula, could tell us that should we all put the blame on the individuals? Maybe the environment or the other things or other factors are affecting people because of those bad issues. You're muted.
We cannot hear Paula.
Yes.
Yes, I think that your presentation has been very, very comprehensive and clear. So my compliments. And so I think that another issue, which as Austin said, which must be taken to proper account is the environment. As I will say afterwards, environment cause more or less 20-25% of deaths across the world in terms of many kinds of diseases, mainly cardiovascular and cerebrovascular diseases, but also cancer. But I think that it is also important to mention diseases, not only deaths. And that is important in terms of global burden of disease evaluation. Anyway, I think that what you said also when you focused on individual attitudes are generally extremely clearly linked to the environmental condition, such as greenness. By the way, Osden has a beautiful background, green background. Anyway, greenness is extremely important in terms of health directly, because for your respiratory safety and so on, but also in terms of well-being as a whole, so social integration, which please do not forget, are extremely important to condition the vulnerability of general people to other conditions such as cancer and so on. That's it. Thank you, Tosden.
Thank you very much. Dear Paula, would you like to share your screen? Now we can see. But we can't hear. You're muted. Yes. But again, you are muted. Muted.
Okay,
Yes.
thank you so much. And thank you for inviting me. It's a pleasure to share some reflection with you on the need to effectively address the migration phenomenon in a planetary health perspective. Okay, so in my presentation, I will cover the following points. Since I will be presenting probably too many slides, I will need to go quickly. However, I will make my slides available for sharing. Okay, why this topic? The growing health challenges faced by migrants worldwide call for a more integrated approach to healthcare services at every stage of the migration path, with a strong focus on local implementation. The key objectives of this presentation are to outline the need for a comprehensive framework for integration, to highlight the crucial role of family doctors and family pediatricians in migrant health, to share insight from the Calabria pilot project. Calabria is a region in Italy, as a practical example of integrated healthcare solution. In other words, the presentation will emphasize a coordinated approach to managing migration-related health challenges, particularly those driven by climate change and conflicts, the role of PHC, primary health care, as the first point of contact, underscoring the importance of strengthening its connection with hospitals and prevention strategies. The importance of data-driven decision-making, incorporating real-world examples such as statistics on migrant health disparities to inform policy and practice. Migrants face significant health challenges, including infectious diseases, mental health disorders, and environmental health impact. These are worsened by legal and bureaucratic barriers, cultural and linguistic challenges, and healthcare system fragmentation, limiting access to adequate care. These issues align with some key United Nations Sustainable Development Goals, SDGs, such as SDG 3, good health and well-being, ensuring universal health coverage for migrants to provide quality health care without financial hardship. SDG 10, reduced inequalities, addressing legal, economic, and social barriers to promote inclusive healthcare policies. SDG 13, climate action, strengthening primary healthcare system to support a climate displaced population and build resilient healthcare infrastructure. First, let's quickly introduce some principle and feature of PAC in a straightforward manner. Let's begin with the most authoritative and widely accepted definition of primary health care as provided by the WHO in Almata in 1978. It is essential healthcare based on practical, scientifically sound, and socially acceptable method and technology. It makes universal healthcare accessible to all individuals. It allows full participation of the community. The ultimate goal of primary healthcare is the attainment of better health services for all. And as such, the WHO identified 5 key elements: reducing exclusion and social disparities in health, organizing health services around people's need, integrating health into all sectors, which is essentially the core of the proposal I introduced afterwards, pursuing collaborative model of policy dialogue, increasing stakeholder participation. This figure shows the three components of PHC as stated by WHO in 2024. Primary care and essential public health function are as the core of the integrated health services, which the aim to meet people's health needs throughout their life. Addressing the broader determinants of health through multisectoral policy and action, and empowering individuals, families, and communities to take charge of their own health, which is essentially the objective of the third Sustainable Development Goal, good health and well-being, which, please note, is the goal I mentioned while dealing with migrant health. The PHC operation framework presented here was developed at the request of WHO member states in 2024. Its purpose is to translate the commitments made in the Declaration of Astana in 2018 into tangible policies and action, thereby accelerating countries' progress towards strengthening primary health care system. In the case of COVID-19, it has been found that primary care physicians are in excellent position to educate patients on hygiene measures, including personal application of contagion containment measure. Additionally, they can detect and report epidemics or mini-epidemics of diseases and provide guidance on the application of guidelines on critical care issues. COVID-19 has highlighted the importance of general practitioners working in coordination with primary and community healthcare providers, as well as hospitals. It has become clear that a multidisciplinary workforce can play a vital role in recognizing and managing the environmental and social factors that affect community health. When discussing the effect, as I said before, of the environment on health, we often start with this statistic. According to the WHO, nearly 1/4 of global deaths are linked to environmental factors. These are the most important diseases linked to the environment, primary cerebral and cardiovascular accidents, injuries, and other diseases such as cancer. Focusing only on the health effects due to climate change, the WHO stated that they will be the cause of 250,000 additional deaths per year between 2030 and 2050. But please note that all those figures are based only on deaths. Hence, what is the real burden of environmental effect on death? In 2009, WONCA, the World Organization of Family Doctors, assessed that in the healthcare system where general practitioners and pediatricians act as gatekeepers, as in Europe, 80% of all patients are initially cared by GPs and pediatricians, and 95% of cases are resolved by them alone. This finding has also been observed in the United States, and these figures have not changed significantly since then. This brings us to the next point. Why targeting family doctors is so important? The health effect associated with environmental risk factor, usually quantified through mortality, emergency visit, and hospitalization, are underrepresented, as many illnesses treated by family doctors and pediatricians are missed in this number. In the case of climate change health effects, there are not lethal health effects, which are early indicators of environmental linked condition, and which, if they are not exactly quantified, could cause disarrangement of the overall health organization and healthcare systems, with remarkable effect on individual and public health. Please remember the case of vector-borne infectious diseases, which exhibit significant geographical variability due to climate change and are often referred to as focal diseases. Conditions such as dengue, West Nile fever, and Zika are particularly relevant on global scale. In these instances, it is essential to implement global strategies that address climate change at the local level. Consequently, the role of local community-based is crucial. Family doctors and family pediatricians can play a significant role in promoting climate change mitigation and assisting communities in their adaptation efforts. In fact, more generally, we are convinced that family doctors can really close the gap between health and environment, owing to the influential role of GPs and pediatricians on individual patients and communities. They can connect global concern with local action. This is an interesting picture published in the Lancet, which clearly shows the role of general practice in planetary perspective. Which activities could general practitioner undertake to address climate change? Please see such a table as an example, and you can see that local GPs are the best choice to handle these activities with utmost effectiveness. This second premise of the presentation will address the migration issue, which will be further developed. I will highlight a few key points for brevity. The World Economic Forum quantified the impact climate change on human health. By 2050, climate change will place immense strain on global healthcare system, causing 14.5 million deaths and $12.5 trillion in economic losses. Climate change induced impact will account for further $1.1 trillion in extra cost to healthcare system, creating a significant additional burden on already strained infrastructure and medical and human resources. It is imperative for policymakers to recognize and address the insufficient readiness of healthcare systems to mitigate health consequences. Collaborate efforts involving multiple stakeholders and industries are essential to address these challenges and to achieve a comprehensive health system transformation. Here you can see labor and earning lost in 2023. This picture shows the lost earnings categorized by economic sectors and the Human Development Index. HDI is a summary measure of average achievement in key dimensions of human development and long and healthy life, being knowledgeable and having a decent standard of living. The health impact of climate change has been stated by Bartler and Hartley model, which summarized and characterized such health effect in primary, secondary, and tertiary impact. In 2023, heat-related deaths of people over 65 years of age reached the highest level recorded 167 higher than in 1999. This is more than twice the increase that would have been expected without a temperature change. A table like this summarizes the type of exposure, health outcomes, and the strength of the relationship between the two. If the temperature reaches 2 Celsius degree by mid-century, heat-related deaths are projected to increase by 370%. Heat-related labor loss is projected to increase by 50%. 524.9 million additional people are projected to experience moderate to severe food insecurity. The transmission of potential for dengue is projected to increase by up to 37%. The journal Nature warns that more than half of known pathogenic diseases can be worsened by climate change. Here are summarized the health effects related to floods. Impact arising during the following drought can be categorized as both direct and indirect. Direct impact include limited water supply, loss of crops, damage to infrastructure, and injury. Example of indirect impacts include ecosystem changes such as changes in breeding conditions, biodiversity loss, and supply chains and disruption, leading to potential food insecurity and malnutrition. As a result of direct and indirect impacts, drought can harmfully affect mental health, increase concentration of certain pathogens or allergens, leading to knock-on health effects, impact food security and nutrition, as well as impacting health system delivery. This higher frequency of heat waves and drought led to a total of 151 million more people experiencing moderate or severe food insecurity across 124 countries, increasing the risk of malnutrition and hunger. And here the health effects of wildfires are summarized and listed. Climatic migration. Climate change fuels health crisis, economic instability, and conflicts, forcing migration. Extreme weather disrupts livelihood, heightens disease burdens, and escalate tensions and wars. As conditions deteriorate, migration becomes a survival strategy, posing new health challenges. This is the example of Syria, where forced displacement due to conflict was exacerbated by climate change. This figure depicts a simple representation of the interaction between individual and classes of drivers. The impact of climate change on food insecurity and many other drivers, such as water political insecurity and human mobility are nuanced and complex, as highlighted in this figure. This table provides a summary of the key statistics reported in the first edition of the World Migration Report in 2000 as compared to the edition of 2024. It shows that while some aspects have been stayed fairly constant, such as the overall proportion of the world population that are migrants, whilst other aspects have changed dramatically. International remittance, for example, have grown from an estimated $128 billion to $831 billion, underscoring the salience of international migration as a driver of development. Also of note is the rise of international migrants globally, but more strikingly, the rise in the number of refugees and internationally displaced persons. Estimating, there were 75.9 million people living in international displacement globally as of the end of 2023, up from 71.1 million in 2022. There were 7.7 million people living in internal displacement globally as a result of disaster at the end of 2023, although data gaps on the duration of disaster displacement make this figure conservative. It shows that, like conflict, disaster can keep people displacement for long period of time. Estimating a future pattern of climate change-induced migration remains challenging, in part because sudden and slow onset climate events have not been considered in many of the models of climate migration. However, 1.2 billion people could be displaced globally by 2050. Such a prediction is valuable because it focuses on economic convergence and the balance between unilateralism and multilateralism. I will now begin describing and discussing our experience in Calabria in this field. These are the figures describing the current situation of migration in 2025 compared with the same day, April 29th, in 2024 and 2023. The majority of migrants on April the 29th originated from the following countries. Asia and the Middle East contributed 50% of this total. In 2021, the majority of people who arrived in our peninsula were from countries that have been severely impacted by drought and floods. These countries include Tunisia, Egypt, Bangladesh, Afghanistan, Syria, Ivory Coast, Eritrea, Guinea, Pakistan, and Iran. They are heavily dependent on wheat from Russia and Ukraine and are currently experiencing famine due to the rise in average temperature and extreme weather conditions, as I shown before. Unfortunately, climate-displaced individuals are often not recognized as refugees under the law, which leaves them invisible and without protection. This is a concerning issue that needs to be addressed urgently. A tragic shipwreck occurred on the night of February 20, the 25th and the 26th in 2023, 20 meters far from the beach of Steccato of Cutro, not in the middle of the Mediterranean Sea, in the province of Crotone, resulting in 94 deaths, including 38 minors. This incident has brought attention to a concerning migration issue that's been largely ignored by the public in that area. In fact, despite being the second port of call in Italy after Lampedusa, Calabria has been overlooked. Even before the Steccato of Cutro tragedy, the route from Turkey to Calabria was a cause for concern due to its longer distance and less surveillance compared to the triangle between Libya, Tunisia, and Sicily. Please remember that in Libya, the dynamics of migration have transformed into a business of detention. According to Parish et al., the health impact of migration can be observed before, during, and after the migration process, as shown in this picture table. Furthermore, it should also be noted that migrants and asylum seekers may face an increased risk of antimicrobial resistance. As such, increased effort are needed to drive improvement in infection surveillance, prevention, and control, including vaccination, antimicrobial stewardship, treatment strategies tailored to group at high risk, accessibility to quality healthcare in this population at risk globally, and address risk factors such as poor living and transit conditions. Coming to Calabria experience, in 2023, we collaborated on developing an inspirational and ambitious project named Workshoe, within the Horizon framework. Also, Turkish people participated. Its main objective was to enhance the capacity of health system to predict and prepare for the impact of climate change and environmental degradation on health, and in particular of refugees, migrant and displaced population. Despite the project not being approved, Calabrian local institutions have decided to move forward. It will be quite challenging, but we will persevere. From the Italian side, we propose some pilot experience. The proposal focused on establishing a network of sentinel physicians. Such a network will be involved to investigate key population health effects such as heat waves, mental distress due to post-migration setting, in mapping existing information system, health, environmental, social, occupational data, and capacities, infrastructures, and formal legacies among institutions, and to integrate of all environmental, social, and occupational data, and developing a preliminary environmental health epidemiological surveillance system in collaboration with all stakeholders institutions. The chosen area is the province of Crotone. It is one of the 5 provinces in the region of Calabria in southern Italy. And what we are doing is we are working on the need to integrate in a planetary environmental health justice perspective people who suffer mainly due to the climate effects, the role of primary care in assisting and particularly in preventing infectious environmental and climatic risks associated with unfavorable socioeconomic conditions that led to migration, the opportunities for integration and collaboration between the healthcare, social, and environmental systems, which should be identified and implemented, the relationship with the local communication system, and a working group will be created to define the pilot experience in the Crotone area. Conclusion and recommendation. Practically, I would like to emphasize the importance of effectively welcoming by means the integration of migrants. Understanding this issue is crucial, as it directly influences what action should be taken, can and should be taken. Consequently, it is essential to raise awareness and improve the competencies of family doctors. Data and real-world examples highlight the necessity of addressing this issue proactively. Ultimately, these matters must be recognized in the context of the legal definition of climate migrants, as well as in terms of resources allocated to this very critical social, economic, and political issue. In addition to effectively address migration-related health challenges, it is crucial to highlight the role of both local and national institutions in fostering collaboration between primary care and public health. Strengthening this integration ensures a more coordinated response to the complex health needs of migrant population. This figure outlines 5 key areas where primary care services and public health system collaborate, as defined in a multi-country agreement facilitated by WHO. Several countries have implemented the integration between primary care and public health, such as Brazil, Slovenia, Costa Rica, Asian countries. In conclusion, integrating primary care and public health is key to reducing health disparities and ensuring equitable access to healthcare for migrants. However, this process must also account for existing barriers, such as bureaucratic hurdles and resource limitation to develop truly inclusive and effective health strategies. As I wrap up in this presentation, I urge you to recognize the significance of striving for excellence ethically, economically, and professionally, and I kindly ask you to reflect on if and how this insight can be actively implemented in your own professional context. Lastly, what suggestion can I offer to family doctors in the field of planetary health? Develop a strong knowledge base, engage in collaboration and global partnership, work with international institutions, particularly in Turkey, to develop climate-resilient healthcare models. Support migrant communities, integrating the Sentinel Physician for the Environment model into health system to improve monitoring and response. Advocate and lead in planetary health. Get involved in policy research and advocacy, shaping global strategies for environmental health resilience. Build a strong network of mentors and peers, leveraging conferences and collaboration to drive real-world impact. Final message to family doctors pursuing planetary health: bridge science, policy, and action. Your work will shape a healthier, more sustainable future. Thank you for your attention. Okay.
Here, Paolo, thank you very much.
Okay, here I am.
I didn't see any question on the chat box, but it is always pleasure to listen to you. Thank you.
Thank you so much.
Suzanne, would you like to say anything?
I'm grateful for hearing dear colleague Paola. This is my first time to have opportunity to listen his lecture, and I'm moved in a lot of issues to think of about planetary health and migrants and opportunities in primary health care. So thank you very much for all ideas I've got from your lecture today.
And we have got another one. I saw dear Enrique there. I guess he is somewhere here. Yes, he is. Hi, you are muted.
Hello.
I learned ciao from Paolo. And would you like to say anything, or would you like to begin your presentation?
We can begin the presentation. Yeah.
All right. So could you please share the screen?
Let's see if I can make it. Can you see my presentation?
Yes, yes, yes. Yes, I do. Perfect.
Okay. So I'm just setting up my my timer. And so I try to have 20-25 minutes, but if I go up to 20, please warn me that I have 5 minutes or at the most 10 minutes. Would you do that, Austin, please? Okay, thank you.
Okay.
So first of all, thank you very much, Austin, for this invitation. I'm always very pleased to collaborate with our colleagues and especially with Austin, which is the leader of our working party on planetary health. So thank you once more, and thank you to everyone watching this. I was asked to talk about planetary health and person-centered care. So this is really a challenge, and I'll try to expose how I think about this. So in 2024, the WONCA declared in the Family Doctor Day, declared that our focus should be healthy planet and healthy people. Why is that? Because a lot of patients, and I would argue all our patients, are interconnected within the planet. This is important. In 2023, the WONCA framework for family medicine included planetary health, One Health, and sustainability. And of course, one of the core abilities or capacities that the family doctor needs is person-centered care. So how do we work both these together? First of all, what is planetary health? This is a model, a framework to understand planetary health that I collaborated with in the Lancet Planetary Health. So we see, first of all, interconnection within nature. Then we see health in the Anthropocene. Now, what is the Anthropocene? It is basically the last 50, 100 years where we saw an age of abundance with all the economic development and health science developments. So we have infant mortality going very much down, life expectancy going up, and basically absolute poverty going down. So this is the Anthropocene. And because we have so much exploration of nature and this hyperpollution, it's starting to affect very highly in health. We'll discuss this further. So we need a movement building for systems change. And for that, we need systems and complexity thinking in order to have climate justice, equity, social justice. Now, how are the planetary health limits? This is a very important graph showing that we have overshot the safe operation space of the planetary health system services. That is, so we have biodiversity, which helps with crops, prevent diseases, land systems, we have erosion, fresh water, we have pollution, biogeochemical, ocean acidification, and so forth. And I'm going to concentrate on climate change. And of course, now we're talking about air pollution and microplastics. So you see that we have basically a lot of climate change and fastly getting worse. So again, the challenge is to go from the person to the planet. How does the person affect the planet? And how does the planet affect the person? And what is the job of the family doctor? Now, this is a patient from my clinic where I take my students, and Sapiranga is the city. So it made the headlines in the New York Times because the patients were taken by boat because of a major flood. This is where I live, the red dot. This is the Amazon. And we had such a major fire, the size of, let's say, greater than Portugal. And the smoke came all the way down to my city. So one of the messages is that pollution has no frontiers. And this actually increases death, as Paolo explained. Now, this is an important graph as well. So we have the climate health emergency, and it is really altered by food systems and basically by fossil fuel combustion. So directly, fossil fuel combustion pollutes the air and kills 4 million deaths by ambient pollution directly. And of course, it does the greenhouse gas, which increases the temperature, raises the sea level, and causes extreme events. And this will always have an impact in our community, as the postal code is more important than the genetic code. My community has been affected by extreme climate events, heat waves, air quality, quality and quantity of water, food security, dengue, and social factors. And I'll try to discuss a few. I have now many climate refugees, and one of the causes of inflation in Brazil and food insecurity is climate. We have a lot of corn and tomato issues. Now we have egg price issues, and they all have some climate impact. And especially air quality, as we saw from the Amazon, we have a lot of heat waves, especially affecting older people. They collapse because of heat waves, and many times they don't have air conditioning, so they have a lot of suffering to sleep, and of course, floodings. So what is Anthropocene? So we have a lot of abundance because of technology and consumerism, but this is driving high pollution and exploitation. This is the disease cascade. it will affect our community, and it will get our people sick. So as a family doctor, we see individual patients in the community. This is my team, and we are part of the primary health care system, which has a direct effect on the postal code, improving equity and health equity. Now, we are part of a national health system, and we help it to get evidence-based. So we improve the effectiveness per resource use. So we directly reduce pollution and exploitation. We cannot underestimate that healthcare systems are responsible for 5% of the greenhouse gas emissions worldwide. So we improve well-being, which reduces the population. It improves technology because we're also more nature-based solutions. And fortunately, it reduces consumerism, and we have less pollution. Now, an example from my clinic, this is where I live. So we have 1 minute for the planet. And I could talk about adaptation, which is important in climate change, and mitigation. And this is sort of both. So I had a patient with fever and rash, and I diagnosed dengue. We shouldn't have this in my town because it's high up in the mountains. And this was the first case that I diagnosed. And so I gave her treatment, and I gave her evidence-based treatment. So we avoided a lot of problems, and we avoided her going to the emergency room. So again, effective, evidence-based, patient-centered care. And her mom, she was wheezing and had dyspnea from COVID. So we could discuss how COVID is interlinked, but it is part of planetary health because it's part of the Anthropocene, and we'll have more and more of these pandemics. So I diagnosed COVID-related asthma, and I treated her with the best medication available, which is dry powder inhaler instead of the sprays, which release a lot of greenhouse gases with the propellant. According to the United Nations agency, it is responsible for 0.03% of all the greenhouse gases. So it's important that we try to change when possible, when evidence-based, to dry powder inhalers. And since I had a few more moments with her, with the child and the mom, I discussed the importance of planetary health to their health, and that was quite evident, and how they could help mitigate. And I told them about red meat and the impact it had on raising more cattle, and for that, knocking down the trees and burning the trees in the Amazon, which would also affect her asthma. I also talked about fossil fuels and how it affected the air, and I advised them to do active transport, which is also improving the health, of course. And I forgot to mention that red meat consumption, excessive, is related especially to colon cancer, but there's evidence that it is related as well to cardiovascular disease, diabetes, and so forth. Now, what is the framework of family medicine that improves person-centered care and planetary health care? So again, we have the mother and child, and we need a lot of access, which is also what my climate refugees need. They need access. So if you have continuity of care, comprehensiveness, and coordination, you have a lot of family orientation, cultural competence, community orientation, which gives you much more ability to understand if that family, if that person are ready to understand climate change mitigation. And of course, when you have community orientation, you can help the community, you can help with more advocacy because you understand the context, you understand the pitfalls, the caveats, you understand the advantages and the disadvantages to do mitigation and adaptation, which are very important. And when you do that, you have planetary health orientation. So I would argue that family medicine and primary care workers are at the basis of planetary health and are the green doctors or the green providers just by doing evidence-based and person-centered care. Of course, it's much better if you get the time to do advocacy and understanding better the evidence. Now, to finalize, this is the healthcare system that we need. I collaborated with this paper in the BMJ. So, of course, we need solar panels. Of course, we need electric cars, but we also can improve reducing the need for hospitals, so making them smaller and increasing the primary health care. So we need more recognition of the importance of family medicine. We need more recognition. We need to strengthen primary health care, which has been proven to improve health while reducing the impact on the environment. Telehealth, which I have a lot of experience with, has helped me a lot to avoid overdiagnosis and overtreatment and sending my patients, which are in a rural community, to the hospital, which is far away. So it saves a lot of fuel and a lot of resources in the hospital. And we actually published a paper on how much fossil fuel we avoided just by doing this sort of stuff. And it's a lot of energy. It's in a few years, it's about the energy of a city. So again, we need to be very proactive. We need to understand that we already do planetary health, and we're good at person healthcare. So thank you very much.
Thank you very much too. Is there anything you would like to say, Snežana?
Yes, I would like to thanks to Enrique a lot of on comprehensive vision of primary health care, and maybe I could find the connection between lifestyle medicine and all activities in primary health care in planetary health in aspect of physical activity. Maybe we in primary health care should more and every day in every practice visit promote physical activity and try on that way to reduce car use, buses, everything, and try to promote bicycle use and on short distance walking. That is, I think, simple and short advice that we can practice in our everyday primary health care work. Thanks.
Yeah,
And
Osden, if you allow me.
yeah, of course,
Yeah,
stage is yours.
okay, so an important aspect I forgot is co-benefits. So when we talk about physical activity, improving health, healthy food, which is plant-based, we reduce the impact in the environment while improving our health at the same time. There are lots of win-win solutions which are basically nature-based. And this is one of the reasons why we are very, very planetary health-centered, at the same time being person-centered.
Paolo, would you like to say something?
No, thank you.
No, it's okay. I thank Enrique. By the way, I showed a slide with which has been taken from a Lancet publication published by him. So I thank him also for this. Thank you.
There is a question about sustainability yesterday in the Congress, because there was a part on face-to-face too. Oh, yes, we would love to see you in Izmir. It will be great if you could do that next year, I guess, if we could find a sponsor. And that comes to the economy. One of our colleagues just asked that if you just divide the money equally in equity, why are we talking about lifestyle medicine or planetary health and so on? Because the people who are just getting into us trouble are the ones who are just getting the money, not the ones who are just having the trouble. And the trouble taker and the challengers one are much more higher in the community. Yes, that's right. But also I give an example about the asthma recipe. And then he said, yeah, yes, if it is so, we could give some more examples. Have you got more examples for our listeners? Enrique, you seem that you will go somewhere. You're muted.
No, it's just that it's cold inside. This is one of the reasons why Brazil has a better footprint. Heating inside the homes is very expensive, so we save a lot on that by using jackets inside. But now I have a solar panel, so I put an air conditioning. So we're improving. Also because of the heat waves. We didn't have heat waves in the mountains when I arrived 15 years ago. And now it's impossible to live without air conditioning.
I see.
We also had ice, so we could walk on ice. We didn't have dengue. And now we don't have ice anymore.
I think we will see much more viruses and bacteria and so on that are not friendly to us. And also we wouldn't have any equipment to improve it. So if so, it will be much more expensive to reach the vulnerable people maybe. Thank you very much. It was great to see you all together, because if just set a table and tell you let's come to the dinner, I think I wouldn't just make it at the same time at the same place, but because of the Congress we made it. Thank you very much once again.
Thank you.
Thank you. Bye.
Thank you all. Goodbye.
Bye.